and welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Today on the show, we have Rita Agarwal. She is anesthesiologist and she co-wrote the Kevin MD article, Pediatric Patients Need Appropriate Pain Management After Surgery. Rita, welcome to the show.
Thank you. Thank you for inviting me.
So we'll get into your article in a little bit, but first off, can you share your story and journey to where you are today?
I'm one of those kids who always wanted to be a doctor from the time I was quite young. I went to medical school at Baylor in Houston. I did my anesthesiology residency there and my fellowship in peds anesthesia in Denver at the now called the Children's Hospital Colorado. At the time it was Denver Children's. I had an interest in regional anesthesia and pain management from really as far back as I can remember, in terms of once I started my training. When I joined the practice at Children's, again, now Children's Colorado, then it was just the Children's Hospital Denver, we were just starting an acute pain service. And so I was one of the early founding, not really founding, but one of the early members. I eventually took over the role as acute pain director. I focused really on inpatient pain management. So anyone who went to the OR and had surgery, anyone who was in the hospital for other reasons who might have acute pain, that was sort of the patient population that I worked with. I moved to Stanford and to Lucile Packard Children's Hospital about 6 years ago and have been a member of the inpatient pediatric pain service here too, and continue very much in the realm of that work, and have a real interest in trying to make the perioperative experience, but also the hospital experience, better for kids in pain.
So I'll be honest, I don't know too much about a pediatric pain service. So can you just share with my audience, what are some
Sure.
typical cases that you see?
Well, I'm glad you asked because that's a great question. So we typically will follow patients who have more complex surgeries or more painful surgeries. So, for example, posterior spine fusions, pectus excavatum repairs can often be quite painful. Major orthopedic surgeries, major abdominal general surgery type cases. So occasionally ENT, occasionally neurosurgical patients with complex pain issues. We also follow patients who have a history of chronic pain who come back for surgery, because oftentimes any patient, adult or pediatrics, it's well proven in the literature their sensitivity is going to be much greater, and so their needs for pain management are also going to be much greater. So even a surgery that is sometimes a day surgery for those of us who don't suffer from chronic pain can be several day admissions for pain management in someone who has a history of chronic pain. We also see a lot of oncology patients who have acute pain flares related to either the treatment or their disease process. We see patients with sickle cell who have pain flares related to that. At Stanford in particular, we are a big center for immunologic and inflammatory diseases. So we'll see kids who come in with flares from like rheumatologic processes, inflammatory processes that get periodic flares and come in and are followed. So we'll follow those patients. That's that's pretty typical, I think, of most pediatric pain services. It's going to vary a little bit from place to place. Any regional anesthetic that's placed in the operating room that's going to
Mhm.
stay in for a few days, we also follow those patients.
So you may be getting into this question a little bit when you talk about your article, but in general, what are the differences in the approach to pain in the pediatric population versus the adult population?
So that varies a little bit depending on the location that pain is being treated. So at Children's Hospital, which is where I've spent the majority of my career, we're much more in tune to appropriate assessment tools, appropriate management strategies. We're much better, not much better, we're much more educated around using non-pharmacologic techniques like distraction, like we've great child life services who come in and do all kinds of activities with our kids. We have great nurses who are really, because this is all they do, they work with kids every day, who are really good at helping manage, some of the pain that can be managed with just things like distraction, touch, massage, that kind of stuff. We did, until COVID, have massage services available in the hospital, which was amazing. We never got to use it, but the
Mhm.
patients did, and they loved it. Many of them loved it. We have physical therapists and occupational therapists who are really in tune to that. In locations where they don't do as much pediatrics, or they're not as used to or as comfortable as pediatrics, I think just starting with basic assessment tools, what's appropriate tool to use to assess a younger child versus an older child, can sometimes be challenging. So that would be the first place. In adults, it's always, 0 to 10. 0 being no pain, 10
Mhm.
being the worst pain. What is your pain? Whereas that may work for a 14-year-old, it's not going to work for a 4-year-old. So that, just starting at the very basic aspects, that can be an issue.
Now, how do you assess pain in someone who really can't express it on a scale?
So there's the FLACC score, which was developed by my wonderful friends and colleagues at Michigan, which and the modified FLACC score, which is faces, legs, activity, consolability, and cry. And it basically looks objectively, or tries to look objectively, at a child, looking at grimacing versus a face that's either happy or relaxed, looking at like legs, how they're moving their legs, looking at how they're moving around in the bed. So it uses a variety of observable
Mhm.
metrics to try and come up with a score, and it's based on a 0 to 10 score as well. So 0 being they probably have no pain, 10 being they have pain, and it's been very well validated in postoperative patients. It's been well validated in children who are unable to express pain, whether it's because of developmental or neurologic issues, or whether it's just age related. So that's one score. There's multiple different scales. Obviously there's not a perfect scale. There's the Wong-Baker FACES scale, which you show faces to a child and they pick out which one they think most closely resembles where they are. There's the Oucher, which actually shows photographs of children's faces. The same basic concept, with a child looking calm or happy versus, really with their face scrunched up and in pain and
Mhm.
crying. And the Oucher is really nice because it's validated for different ethnicities. There is like a Caucasian Oucher, an African American culture. I know there's a Hispanic, Asian, and I think they were at least working on a Native American one as well. There may be one out now, I can't remember. But there's multiple different scales that can be used in different institutions to try and get the best estimate of what the pain is in the child as possible. We let parents help with that because
Mhm.
they often know their children the best and can really say, especially for children who are developmentally delayed or who have other neurologic issues that might make it more difficult for them to let somebody know how much pain they're having. Parents are the best judge of that 100% of the time.
So let's transition now into the Kevin MD article that you co-wrote. It's
Sure.
titled Pediatric Patients Need Appropriate Pain Management After Surgery. Now, for those who didn't get a chance to read that article, can you just walk my audience through it and share the story of why you decided to co-write it?
Sure. So we wrote it in response to an article that came out in JAMA Surgery, which was an excellent article. I'm not just so to be clear, it was an excellent article by Dr. Kelly Kwan and colleagues. It was a multidisciplinary, multi-institutional set of guidelines that were produced in JAMA Surgery to help guide clinicians regarding pediatric pain management. Our concern was that the first five of their recommendations they really emphasize addiction and abuse issues much more so than they emphasize appropriate pain management. And our concern was, with that article, they also talk about opioid free, which is kind of the new exciting buzzword of let's do all of these surgeries without using opioids, which is a laudable goal, but we're not quite there yet. We're not quite ready for prime time yet. We can often get kids through, and adults through a big surgery without using opioids, by using regional, by using dexmedetomidine, by using other medications. But oftentimes, once they hit recovery, they do end up needing opioids. And so we felt like this article was a little bit misleading in that um, and in that particularly because recommendation number 1 through 5, which I'd have to go back now and reread, is we're basically really focusing on the abuse potential of opioids. And our concern was that clinicians, particularly those who are not primarily in the pediatric world, who do some pediatrics or who do minimal pediatrics, might be really dissuade from using opioids even when they are appropriate. We agree with the article itself really focuses on the article by Kelly Kwan in JAMA Surgery. It talks about multimodal, and
Hmm.
what we really wanted to do in our Kevin MD article is to kind of alert people that yes, opioids can be abused, and yes, adolescents are amongst the population that is the most experimental in terms of just trying things. And yes, the majority of adolescents who do experiment with opioids get them either from their own leftover prescriptions or their own or from family members, friends, neighbors prescriptions. But it's a small minority of patients. And there was some things that they quoted in their article that when we went back and read the source materials weren't quite as posted in that article. So that was why we wanted to write the article, is to basically say there are a lot of different ways to treat pain in children. Kids, are great in that they're easily distractible. When you see that kid who's sitting there playing on the phone, that's a great distraction
Hmm.
tool. That's a great tool. Don't discourage them from doing that. Let them use it. If they're playing on their phone and talking to their friends or on social media or whatever it is that they're doing, they're focused on something other than their pain. Their attention has moved away, and so consequently they're oftentimes need less pain medications. There's a lot of other medications that can be used, acetaminophen, tried and true Tylenol, it's a great drug. All the nonsteroidals in varying degrees and varying types, Toradol for the IV version, ibuprofen. I mean, all of those drugs are great, and to using all of them together. So emphasizing a positive, active approach towards multimodal pain management versus avoid opioids.
Hmm.
Opioids are bad. Opioids can cause addiction. That was sort of our goal, was to try and really bring people around, and which is what we've been doing, what I've been doing for 30 years. What I was early in the opioid epidemic when people were focused on the adult issues. I am still part of the American Academy of Pediatrics, and I presented a resolution there regarding opioid use, and people at that time were looking at me like, opioids aren't a problem for kids. So, I mean, I'm well aware of the literature around this, but the bottom line is it's a small minority of children, of adolescents who abuse opioids, and people should not be afraid to give opioids because of that potential. But what they should be doing is using appropriate dosing and appropriate amounts. So when a child gets sent home after a surgery, instead of sending them home with 50 oxycodone, knowing that they're probably only going to use 5 or 10, maybe send them home with 5 or 10 oxycodone, and then if they need more, they can hopefully call and get a refill if that's needed, or at least the physician or someone in their office can evaluate what's going on and decide what they need to do. So we agree with the don't send everybody home with 50 opioids, but we don't agree with the strong emphasis on they're going to abuse it. Kids are going to sell their drugs. Kids are going to use their drugs in ways that are inappropriate. And we're also a little concerned about the really strong emphasis on opioid-free, because I just don't think we don't have enough adjuvant medications yet, particularly ones that kids can go home with, that can replace opioids safely and effectively in some patients. Can definitely be done in some patients, but not in everyone.
So I'm an internal medicine physician, and of course, in the adult population, there's tremendous emphasis on that connection between habit-forming potential and opioids. So I know you alluded to this in your answer in the past, but just so I'm clear and my audience is clear. So what is the habit-forming potential of opioids in the pediatric population? And I guess you could stratify the pediatric population into adolescents and non-adolescents as well.
So specifically in adolescence, I think in the non-adolescent group, part of it is we don't actually have great literature on any of this. The literature that is quoted is often from all kinds of medications. So there's a group again out of Michigan called Monitoring the Future that does these annual surveys of middle school, high school, and now college kids, looking at a whole variety of different things. But amongst that, looking at habits and behaviors, amongst that is opioid use and misuse. I mean, I don't know that we know what percentage of children will develop habit forming, what the actual habit forming potential is. We know that it definitely does occur. Beyond that, is it 1% of the population? Is it 10% of the population? Is it higher? We don't really have a good sense of that. The thought is it's probably around less than 9 to 10%, but it's hard to it's hard to really come up with a number because those studies are minimal. One of the studies that was quoted was a study done, I think, in Detroit, looking at two different high school groups of kids and asking kids, and these were all survey based. So you and I know that surveys can help get a lot of basic information, but there's a whole host of problems that come along with surveys, especially asking high school kids questions. We never know if they're going to answer it truthfully or not, right? But asking, if approached to sell a medication, would you do that? Well, there was a large percentage of kids who said yes, they would. If they were approached to sell their prescription medications, they absolutely would. But when you go back and read the actual article, it's really in reference, it was primarily kids who are on ADHD medications, and not so much opioids, primarily because there's more kids on ADHD medications than opioids. So we don't know. So the simple answer is we don't know. We know that there is a potential. There's no denying that there is a potential, and that there's also no denying that children who are exposed to opioids as adolescents, whether for appropriate prescription and medical uses versus non-prescribed use, do have a higher incidence of going on to abuse those and going on to use heroin. That's a study actually that also Dr. Kelly Kwan did a few years ago that was published in JAMA, that looked at just high schoolers, again, survey data of one high school in LA, that they did that study, and they looked at kids who were given opioids for some surgery versus kids who never used opioids during high school versus kids who used it outside of appropriate prescriptions. And obviously the kids who used it inappropriately had the highest incidence of going on to persistently use. And then they looked at heroin use as kind of one of their outcomes. They had by far the highest incidence, but any kid who had gotten an opioid during high school had a higher than the kids who didn't get any opioids percentage use. It's still only 2 to 3%, but it's more than the kids who didn't get any opioids in high school in terms of their use. So it's clearly there. How to quantify that, it's difficult to say. We see lots of kids who go home on opioids and come back for other things and are not misusing them. So it's a fine line, it's a balance, and we just wanted to try and present we feel like more balanced viewpoint. Use them when you need them. Don't use them if you don't need them, and think about how much you're using.
We're talking to Rita Agarwal. She's an anesthesiologist, and she co-wrote the Kevin MD article, Pediatric Patients Need Appropriate Pain Management After Surgery. Rita, give us a sense of how this argument is playing out in the pediatric pain management world. What is the response to Dr. Kwan and colleagues' article in JAMA Surgery and a response to your article on Kevin MD?
So the response to my article in Kevin MD, or our article, because I co-wrote it with two of my fellow board members from the Society for Pediatric Pain Medicine, which at the time I wrote the article, I was the president. Now I'm the immediate past president of that society. One of the reasons we started this society, and I was one of the co-founders of this society, was really to address these kinds of issues, is to try and figure out the best ways provide appropriate pain medication for children or pain management for children with acute pain as well as chronic pain. The response to our article in Kevin MD was overwhelmingly positive. It was really, really excellent in terms of engagement and in terms of positive comments that I read. There wasn't a ton of comments, but there was a lot of the ones that were there were grateful, and they included a couple from patients, which I thought was really nice. The response to the article in JAMA Surgery, at least amongst the pediatric pain world, and we're lucky enough that we have a pediatric pain server list that's just an email-based server. So we have a lot of people, both nationally, internationally, and from multiple disciplines, who are appalled. They all responded to it very similarly to the way we did. And again, our letter to the editor of JAMA Surgery was just published on the 2nd of June of this month, with a response from Dr. Kelly Kwan and colleagues. And, in their response, they say, well, we're really not trying to focus on the abuse potential of opioids, and arguing some other stuff. And my sense is we all really want what's best for kids. But I will tell you, amongst the pain population that is on this listserv, we were outraged. We felt like it wasn't just myself and my colleagues on the Society for Pediatric Pain Medicine. It was this broader international group, as well as groups that are multidisciplinary, who were outraged because they really felt like this article was giving the impression that all kids are going to go out there and abuse drugs, and that you shouldn't be doing opioids at all. I know that's not what the authors intended. I know the first author, and I know a couple of the other authors very well. So I know that is not what they intended, but that is certainly the way it came across, I think, as just someone reading that particular article.
And my final question, what's your take-home message that you want to leave with the Kevin MD audience?
Yes, please treat pain appropriately. Start with the basics. Start with acetaminophen. Acetaminophen round the clock is an excellent analgesic. Add on nonsteroidals if there's no contraindications to their use. Again, think about round the clock use for very acute pain situations where the pain is likely to be occurring most of the time. PRN if the pain is intermittent. And then, think about other things that you can do. Absolutely think about things like distraction, biofeedback. There's a ton of apps out there that can help with things like meditation. That can be, it's not strictly biofeedback, but that can really help with calming. Think about non-pharmacologic techniques. Think about kind of the mind-body connection. Kids are very good at a lot of these things. Distraction is huge. TV watching, let the kid play it, have as much screen time as possible during that acute recovery phase. It's totally fine during that time, because if it's helping distract them from their pain, they're not going to need as much, and they're not going to feel as much of the discomfort that could be coming from that. But use opioids if the kid needs it. If it's a big surgery, a big broken bone, a big a pain flare from something, use opioids as prescribed by your physicians as needed, or prescribe appropriately. If you have any questions, please call a pediatric pain team. Please go to the SPPM website, which is pedspainmed.org, I think. I should know that off by heart, but I don't. But it's if you look up Society for Pediatric Pain Medicine, we have a section for frequently asked questions. We also have, under one of our tabs, I think it's under resources, local, all of the pediatric pain services that are available throughout the country and some internationally. So most of us are always willing. We get calls all the time from people who want advice on how to best treat a pain problem in a child. So please call someone who knows. Go to the website. You'll see a lot of great information on there, and you may even be able to get some of your questions answered without having to call someone. But contact someone locally if you, or someone nearby, or someone, if you're calling by phone or virtually, there's a lot of places you can call to get advice.
Rita, thank you so much for sharing your time and insight, and thanks again for being on the show.
Thank you so much for inviting me. I really enjoyed this, and I hope this is useful for the audience.